Okay, I'm going to talk today about basic chest x-ray interpretation. To give you a little background, the first 5 years of working as a nurse practitioner, I worked in a pulmonology office, so I read at least 10 to 20 chest x-rays a day, and so the more you do it, the better you get. So let me just show you a few of the tricks and tips that I've learned over the years. So to be successful in interpreting a chest x-ray is that you have to be thorough. It's just like with a 12-lead EKG, where you first identify the rhythm, second, look at the rate, and then go through all the leads to see what is normal and abnormal. You have to be thorough, look at everything, and read the film the same way every time. Always start with whatever you're going to start with and end with whatever you're going to end with. Excuse me. And do it that way every time. The old saying is, you have to learn how to be good before you can be fast. Don't try to be fast before you're good. You have to get the basics down, and then as you do it more and more, you will get much better. And the way you practice this is on any chest x-ray report you get, you can also look at the film, and you can follow along, or in fact, before you even follow along with the radiologist report, you can look at the chest x-ray, the raw film, on your computer, and then go ahead and read the radiology report and see what they had to say about it, and see if your interpretations match. Excuse me. And if you do see something that you don't quite see or you don't quite agree with on the radiology report, don't be afraid to call the radiologists. Radiologists are lonely little people. They sit in a dark little room the entire day. They love to talk to people because they just see these films in a vacuum. They have no idea what's going on with the patient other than their name, their age, and your 3-word blurb about why you're getting the chest x-ray, either shorter breath or cough or fever. They know nothing about the patient. And sometimes when you know the history of the patient, the history sort of clues in the radiologist to what there's, to clues them into the diagnosis of what they're seeing on the chest x-ray. And last but not least, be very familiar with what a normal chest x-ray looks like. Once you know what a normal one looks like, the abnormalities will pop out very quickly and it'll be very evident. So let's talk a little bit more about what a chest x-ray is all about. I always like to think of a chest x-ray, it's a 2-dimensional image of a 3-dimensional object. And you can think of it like shadow puppets. You put your hand up, you have a light source, and then on the wall you can see a shadow. And that's what you're seeing with a chest x-ray. You are seeing a shadow. But instead of using a flashlight, you're actually using an x-ray source. Now, x-rays are different from light in that the energy can actually go through solid objects. Now, it can go through solid objects at differing amounts. The more dense the object, the more x-rays that object will absorb. So air doesn't absorb any x-rays, and it will completely develop the x-ray film in the days where we used to have x-ray film, and it will turn up as black. Whereas if the film is undeveloped, if it doesn't receive any x-rays, it will show up as white. And then we have everything in between. So air, or an air-filled container like your lungs, will typically be black. Whereas if you have soft tissue, like over your heart shadow, that will be shades of gray. Bones, the denser the bone, the more white it will be, and they typically turn up as gray. If you have something very dense, such as fluid or metals, like a pacemaker, they absorb much more of the energy, developing less of the film, and will turn up white. Now, to be thorough in going through chest x-rays, you have to have a modality. I'm going to look at this first, this second, this third. And a lot of people call it the alphabet method. I typically use the A, B, C, D, E, F. I've seen it go out to H on occasion, but this is what I was taught, and this is what I typically use. So when you think of A, B, C, D, E, F, A is airway. And when you think of the airway, we think of the trachea. The trachea should be midline. And then we also want to look for the carina, the first bifurcation past the trachea going into the left and the right lung. So here is an example of a normal chest x-ray. Be very familiar with this. This is how a normal person should look like. You look at it and you say, this looks normal, and you can identify all the normal parts. This is our airway. So let me back up a little bit. So our airway, again, comes down, it's midline, and then we can see right here, there's the carina, there's the split. It should look like a narrow V shape that's upside down. And there I highlighted it for you to follow down. Again, we go back, there it is, right down there. And it should be a nice narrow V. If that V is split, if it's wider than that, then that indicates some pathology, or if the trachea is off to the left or off to the right, something is moving it that way. That gives you a clue on what is going on with the chest x-ray. The next letter is B. B is for bones. We should be able to count 9 or 10 ribs above the diaphragm. And then we also look at the clavicular heads, these guys right there. And that gives us a centering. That tells us that the patient is not twisted to the left, not twisted to the right, not all cattywampus in the bed, and that we are looking at someone that is in the correct posture for a chest x-ray, that we don't have to make that mental calculation of, oh, this image on the chest x-ray is weird, I don't know why, when you look at the clavicular heads and you say, oh, well, it's weird looking because the patient isn't centered. You just have to make that mental adjustment for it. So going back to our normal x-ray, we count the ribs. So this is rib 1, 2, 3, 4, 5, 6, 7, 8, 9. We look at the spinal processes going right down the middle. No scoliosis, no kyphosis, no lordosis, just straight down the middle. Here's our clavicles, here's our clavicular heads. You can see they're equidistant from each other in terms of the trachea. So the head's right there, the head's right there, trachea's in the middle. This is a properly centered patient with good inspiration, and the patient is looking right at us. Here I've highlighted all the pertinent bones. Again, 1, 2, 3, 4. I was actually off a rib. I missed this one up here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 ribs. We can definitely see. We can see the vertebrae. We can see the clavicles, clavicular heads, nice midline. One is not, it's not crooked going like this. It's not crooked going like this. The head isn't on the right one, isn't over here, where the head on the left one is over there, meaning that they're off center. This is looking right at you. C for our ABCDEF method is cardiac. We need to recognize the heart size and position, and we also need to recognize the size and position of the pulmonary arteries. So looking at our chest x-ray, we can see that the heart shadow is here. And we see our pulmonary arteries. There's the left one, there's the right one. And you can see where the arteries branch off. You know, the left pulmonary artery branches off right here, going up and down. The right pulmonary artery branches off here and here, going down. See that this level is not the same level as this. This is normal. This is what it should be. We should see about a 20 or 30 degree difference going from right to left. It should be uphill sloping, not real crazy like up here and down there. And it shouldn't be across, and it shouldn't be like this. It should be what I'm seeing right here, it should be going up like one rib. So going from here to there, about that space, about a 20 to 30 degree angle. Here I've highlighted the pertinent parts of the heart shadow. So again, here's our pulmonary arteries. You weren't able to see them before. Right there and there, again about a 30 degree angle. The red section here, this is the aortic knob, right there. And then, I know on a heart shadow it just looks like one big blob, but this section over here represents the left ventricle, the right atrium, and the left atrium. So if you see something kind of poofed out, you can sort of, you can tell if someone has heart failure, or, really can't tell cardiac mass or anything like that, but this is about the general location of the chambers of the heart in a chest x-ray. And here's some more examples. See, this one is a little bit, have the left pulmonary artery here, the right here. See how they're even there? So that tells us something's not right. Something's pulling this up for some reason. Then we have our normal cardiac shadow. The other thing I wanted to mention, and that wasn't what I meant to mention in this film. My presentation's 10 years old. Sometimes I forget what I was talking about. The other thing you have to watch out for is projection with the cardiac shadow. Sometimes the cardiac shadow will look artificially large. Remember the example I mentioned before about hand puppets, shadow puppets. And that's an apt example here, because if you look down here, it says PA projection. So that means that the X-ray source is starting from the posterior to the back and going to the front. So this patient has their chest up against the wall, and then the X-ray source is behind them, and the light is shining, or the X-ray light is shining through their back and then going through their heart shadow into the front of their chest and then right to the X-ray film. So there's not a lot of distance between the heart and the X-ray film. Now, if you look at this other side, this is an AP projection. Same patient, supposedly. I got these films off the internet. But you can see how much bigger the shadow is. And that's not because they're in heart failure, though. Looking at this film, I probably would say, yeah, they may be in heart failure. Actually, I think these are different patients. But the point I want to get across is that when you do an AP projection, the heart shadow will be artificially enlarged, because with the AP projection, our X-ray light source is facing the front of the chest and the film is on the back. So if you had shadow puppets, if you put your hand closer to the light source and farther away from the wall, the shadow will be larger. If you put your hand closer to the wall, the shadow will be smaller. Same thing happens with X-rays. The closer your heart is to the X-ray source and farther away from the film, the larger the heart will look. So if you're thinking they have cardiomegaly, please look at the projection. Was it an AP view or a PA and lateral view? And that may also help out. Now, looking at this guy right here, I would say that he is probably a little bit of heart failure. It does look a little fluffy, though I don't see any pleural effusions. But we'll get to that in a minute. The other thing you have to watch out, or the way you determine if a person has cardiomegaly or not, is by comparing the size of the cardiac shadow, the lateral size of the cardiac shadow, to the thorax. As you can see here, I have my red line that goes across, and you typically would put your finger up against the film to get like a rough estimate. You then take that, and then you put it again, you take that size and you just move your hand over and see, does this width smaller or larger than the hemithorax, the one side of the chest? If it's less or equal, then it's a normal sized heart. If it's larger, then you do have some cardiomegaly. But positioning of the patient can also affect that cardiac size. This is all the same patient. Whoop, go back over here. This is all the same patient, but the patient is rotated. So here, they're rotated off to the left. This is center. This is right, and you can see they all have different size, even though we're looking at the same image or the same anatomical organ. And because of the size, because remember, we're looking at a three-dimensional object in two-dimensional space, how the organ is presented will also determine its size. Next, we'll go on to D, which is the diaphragms. Are they in the correct position? Remember that the right diaphragm that's over the liver should be higher than the left diaphragm, which is over the stomach. We'll typically see an air bubble over the left diaphragm, which is basically an air bubble in the stomach. We check the costophrenic angles, meaning the angle between the sides of the thorax where it meets up with the diaphragm. There should be a nice sharp angle, and they should also be the right shape. They should be rounded, not flattened. So again, looking at our sample patient, we see our diaphragms. We see that our right diaphragm is higher than the left diaphragm, because remember, we have liver over here, we have stomach over here. Stomach / intestines have air bubbles, which you can definitely see there. We see, and then we can see a nice sharp costophrenic angle. We should see it all the way down, and it should form a nice acute angle. It should not be blunted. Sometimes they're blunted down there, which means they have a little bit of fluid. Sometimes you'll see fluid all the way up here, but they should be nice and sharp. And here I highlighted the diaphragms if you couldn't see earlier. E is what I call everything else. Markers, lines, foreign objects. You also want to check for breasts, because sometimes breasts, especially large pendulous breasts, can cover a part of the chest x-ray. And over in our example, the only foreign object we have is this marker up here. It says L for left, and typically when we shoot an x-ray, we will see a marker there to differentiate left from right. Here's an example of pendulous breast shadows. You can see that it sort of covers up a lot of the lung fields here. It makes it sort of look like it's got pneumonia. It's not pneumonia, that's just large breasts. Here's more examples of foreign objects. If you worked in the ICU, I'm sure you've seen this multiple times, but you can see our marker right here, right. We have our endotracheal tube that comes down. Usually that has a radiopaque line that comes down, and you want to march that down to the tip. Tip's right there, because you can see that line going right down until it stops. You want that about 2 centimeters above the carina. Carina, of course, is right here, so that's in the correct position. You don't want it down here in the right lung. You don't want it up too high. That's a correctly positioned ET tube. You see the EKG lines here. We got an oxygen line up over there, and then over here, going down to stomach, right down there, we got our nasogastric tube. Finally, we get to the end, to the F. F is lung fields, the meat and butter. The reason why we do the lung fields last is because being quick and not being thorough, we jump to the lungs and say, oh, you got pneumonia, and go on. Not always the case. You always want to look at everything else and see how it impacts the meat and potatoes, the lung fields. So in the lung fields, we check for infiltrates, masses, edema, etc. And are they filled with air fairly symmetrically? So again, looking at our sample patient, lung fields, left lung field, right lung field. Pretty easy to see. But they're also divided into the different lobes. We have our right upper lobe, middle lobe, and lower lobe, as well as our left upper and lower lobe. And hidden in here is the lingula, which is the small little appendix-like portion of the lung, our vestigial lung that was crowded out by the heart when the heart formed, and that takes up that space. The horizontal fissure is basically where the upper and middle lobe of the left lung field are meeting. That's this one right here. That's the horizontal fissure. So we should see the upper lung overlap with the middle lung, and that should make a nice little line right there. That's our horizontal fissure. We can tell, we looked at that as a landmark to see if the lung tissue itself is being displaced upward or downward. Looking at our lateral view, which is extremely helpful, we have our upper lobe, middle lobe and lingula, and then the lower lobes in the back. And when we look at this, remember for the PA view, the X-rays are coming this way. So we're making our shadow puppets with light coming through here, so it can go through multiple layers of tissue. And if we have like a pneumonia right here, well, where is it? Is it in the upper, the middle, or the lower? This is how we determine where in the lungs it is by the side view. Remember not to jump ahead to a snap diagnosis, because you may be missing something. And let's talk a little bit about diseases that we'll see in the lungs. The first one is going to be atelectasis. Atelectasis is a state of alveolar collapse, which means that the alveoli, the grapes that hold all the air where the capillaries are surrounding these air pockets to exchange gas, have collapsed. They're just full of mucus. There's no air present in those little sacs. And because it's collapsed, it will shift the different lobes of the lung. So we could see a mediastinal shift, we could see an elevated diaphragm, we could see a vague density. We could also see the air bronchograms. We could see the more solid tubes that bring the air to the lungs. They may be more prominent. I always tell people you should think of atelectasis as with your lungs being a sponge. And then you put Elmer's glue on the sponge and you squished it. And then you opened your hand. What would happen? You have a very teeny tiny little sponge that's full of glue, and it won't inflate again. And that's what's happening with atelectasis. It's just so full of mucus, it won't inflate. Here's an example of atelectasis. So again, this right here is the horizontal fissure. Remember, in our previous X-ray, it was across right over here. And with that atelectasis, that squeezing of the lung tissue where it's collapsed, you can see that it's pushed downward, and we see this hazy density over there. On our lateral view, remember, we have our upper lobes over here, middle lobes over here, lower lobe is in this area. This is a middle lobe atelectasis because you can see this very dense area right here. And that's where the lung has collapsed. So going back here, that is going to be a right. Again, because our X-ray is going from front to back, we can't tell is this lower lobe or middle lobe. But when we go to the lateral side, we can say, it's a middle lobe atelectasis. And you can say, well, John, who the heck cares? Well, it matters. Whoops. It matters because then you have to think, well, why are they having atelectasis there? If it's not going to be an aspiration pneumonia, because remember, aspiration pneumonia typically goes right down to the right lower lobe. This could be a cancer. What's this white spot over here? That could be a mass that's blocking off, the airway to that right middle lobe. So, when it comes to pulmonology, you need to consider which part of the lung is affected, because that will impact your further treatment and what you're thinking of what could be the cause of this. Here's another X-ray with atelectasis. So remember, before I was talking to you about the pulmonary arteries, we should see one right down here, and it should make a nice 20-degree angle. You see that the pulmonary artery is up here, higher than the left, making about a 10-degree angle. So you can see that that's really shifted upwards. It should be down here. So when you're reading your X-ray with the ABCDEF method, you should have been clued in that something's going on at letter C, because this is being pulled up, and you have to say, well, why is it being pulled up? When you get to the F, to the field, you can see a dense mass up here. So this is all atelectasis up here. It's all squished down. Nature abhors a vacuum, especially in a lung. and the lungs are going to try to fill that space. So with that upper lobe being smushed in a tight little pocket like that, the middle and lower lobes are being stretched to fill that vacuum. And you can see it again on the lateral x-ray. Remember, upper lobes in this area, middle lobe in this area down here, and then lower lobes down here. You can see very clearly this is an upper lobe atelectasis on the lateral view. On this example, you're looking at it and you can see this big triangle business here. What are we missing? Well, this is the aortic knob, but you can see this big density right over here that's not being inflated out. On the lateral view, and you say, well, geez, is this like a middle lobe, like a lingular thing, or is it a lower lobe issue? On the lateral lobe, you can see that this area over here, again, upper, middle, and then lowest over here. You can see the lower lobe is full of a gray area, suggestive of a lower lobe atelectasis. So this would be a left, because you don't see anything on the right side. I know all over previous examples we've seen right-sided atelectasis. This one is a left-sided atelectasis because this is relatively clear, but we see our haziness here. And then on the lateral side, we see this density on the lower lobe section. So this would be a left lower lobe atelectasis. This is a cabbage patient. You can tell by the sternotomy wires and the old cabbage lines. And then here in the base, we can see this hazy density down here. And again, looking at the lateral views, you can see this haziness down here on the lower lobes. So this again would be a left lower lobe atelectasis. So how does that differ from pneumonia or other consolidations? So pneumonia again is an infectious process. So it's basically an inflammation of the lung tissue versus a collapse. Atelectasis happens relatively quickly. If you, for example, were to intubate someone and go down the right mainstem bronchus, you don't have any air to inflate the left side, so you'll see a lot of atelectasis happening on the left, sometimes even on the right if you go way far down and bypassing the bronchiole that go to the right upper lobe. So again, it's a slower progression. You will see air bronchograms. You may also see a dense hilum, the tissue that is between the breastbone. That's where our lymph nodes accumulate, and as they get filled with infectious material, it will become dense. Now, a clinical picture will also help in this diagnosis. For example, if they have a high WBC count, if you have an H&P, that is indicative of an infectious process. That will also help to determine if they have a pneumonia. So looking at this x-ray here, we can say, oh, well, how was that different from the atelectasis that we saw in the previous film? Remember, we saw that one earlier, several slides ago, that was very dense. It was right all up here. Let me go back to that slide real quick. There it is. So see this one, how dense that is, and that looks very similar to this one over here. So how can I say this is not an atelectasis? Well, going through the A, B, C, D, E, F method, A, I have airways, so I got a nice V'd carina. Okay, nothing's yanking on that. Over here on our other film, you can't really see the carina at all. I can see that the trachea is maybe a little deviated to the right. Okay. Okay, B bones, 1, 2, 3, 4, 5, 6, 7, 8. I'm seeing like 8 or 9 ribs, which is fine, so that means they inhaled. Cardiac shadow here, okay, and then our pulmonary arteries. So I got a pulmonary artery here and a pulmonary artery there. We have our nice 20-degree angle, where on that previous one, we did not. In fact, this was pulled up. Again, because that atelectic tissue was all smushed, the lungs had to inflate and fill that space. Diaphragms are normal, doesn't appear to be any pulmonary edema. We can definitely see something's going on up in the right upper lobe, and on our lateral view, we can see this vague density here. Now remember, on the lateral view on that previous one, you can see how it was more wedge-shaped, a lot thicker, a lot denser. That's atelectasis. That is pneumonia, okay? And then we can also see those air bronchograms that we were talking about earlier. You can see those stripes. Those are the tubes that are bringing air down to the subsegments of the lung. Looking at this one over here, airway looks fine. We have a good carina, B bones, 1, 2, 3, 4, 5, 6, 7, 8, 9. We're good there. Good cardiac shape, pulmonary artery here, pulmonary artery there, 20-degree angle. Diaphragms, can't really see the costophrenic angle there, but we do have large pendulous breaths. We do see a costophrenic angle there. Saying that, looking at the lateral view, costophrenic angle here, costophrenic angle there, both of those are sharp, so that's how you can determine the absence of pleural effusions on a lateral angle where you couldn't see it on the PA view. And then looking at the side, we see it looks like a right middle lobe consolidation, possibly, or it could be right lower, not quite sure. Looking at the lateral view, we see this density right there. Again, lower lobes. Looks like we've got a lower lobe pneumonia. Middle lobe looks pretty clear. Upper lobe looks clear. So that I would say would be a right lower lobe pneumonia. Pneumothorax. So remember that there has to be vacuum integrity in the lung for the lungs to work. There can be no air between the lungs and the pleura. And if there is air in between the lungs and the pleura, you get a pneumothorax where the lungs can't fully inflate because of the presence of air, and the lung collapses on that size. And they range in size from very, very small to quite large. And then we have our emergency tension pneumothorax, where the air pressure inside the thorax increases to where it actually pushes over to the other side of the chest, pushing the heart and the other lung over, where you have a large volume of free air in there that is not being used for ventilation. So let's look at this chest x-ray again, doing your ABCDEF method. A for airway, good carina. B for bones, 1, 2, 3, 4, 5, 6, 7, 8, 9. Good on both sides. Cardiac shadow, looks fine. All right, now here's where we got the metal in the road. Pulmonary artery here, pulmonary artery there. It's flat. Okay? Something's squishing and pushing the lungs. That should be clue number 1, that there's something wrong. Next one, diaphragm. Got a good hump there, got a good hump there. It's wide, but nothing horrible. And we see a good costophrenic angle there. All right, for diaphragms, don't see any markers. I see like a little EKG patch, nothing big there. And then the fields. All right, so remember, black is air, gray, light gray is tissue. And look right there, you can see this margin right along there. Look very closely. You'll see a difference in gradation. The lungs typically will have blood vessels in it, and it'll be slightly grayer than free air. So that I would consider to be a small to medium pneumothorax on the left. Okay. This is a tension pneumothorax, and let's go through our steps. So we have our A for airway. So here's our airway, and we can say, whoa, something's going on. I don't see a left side, left mainstem bronchus. All I see is a right, and it's being pushed. So you can see the tracheal deviation over here. B for bones, 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm thinking there might be some rib fractures there. I'm not entirely sure. I think we got some rib fractures there. So that would be trauma. C for cardiac, that does not look like a normal cardiac shadow, does it? Here's our pulmonary arteries flat across. Something is pushing and squishing right there across. D for diaphragms, hump, little flat there. You can see that's not a nice concave shape, a little deformed. E for everything else, we have our markers, we have our EKG patches, and then the lung fields. So again, you can see right here, here's our lungs. This is totally collapsed. Total collapse of the left side. We can see air, and we can see the little blood vessels. And right here is atelectasis, because all that lung is being squished down from the free air in the chest wall. And you can see it's all pushing off to the side. Again, we've got that tracheal deviation, and we can see just a lot of blood vessels here on the left, because I think all the blood is being shunted off to the right side. So this is an emergency. This needs an emergent chest tube. Here's another example of that. I won't go through what I did on the previous one, but you can see just the lung tissue here. The diaphragm's malformed over here. We're starting to get some atelectasis over on this side. This is completely non-functional lung. Here's another example. You take a first look at it and you say, But again, going through A, B, C, D, E, F, airway, deviated to the left. Bones, 1, 2, 3, 4, 5, 6, 7, 8, 9. And it looks like we could even see a 10th or 11th rib down there. So this one, we're seeing a lot more bones on this side than over here. Cardiac shadow, I can't really see it. I can't even see the pulmonary arteries. So that should raise red flags. Diaphragm, look how deep that costophrenic angle is. It should be up here. And what we're seeing is just like a hyperinflation of the lung. Here we can't hardly see the diaphragm at all. E, lung markers, we see the left side. And then lung fields, again, this is very black in comparison to this, which is almost white with the atelectasis. We're seeing a very large tension pneumothorax here on the right, shoving everything over to the left. This is a non-functional lung right here. That's what we're seeing. Congestive heart failure versus pulmonary edema. Again, as a result of edema forming within the parenchyma of the lung. We'll typically see increased vascular markings. We'll see a phenomenon called curly B lines. We'll see lower lobe consolidation, pleural effusions, and large cardiac shadow. So here's a typical example of a heart failure chest x-ray going through our modalities. Again, A is for airway, so we can see our airway go down. We really can't see the carina very well, but we can see that the trachea is midline. B for bones, we're looking at 1, 2, 3, 4, 5, 6, 7, 8. Can't really see beyond 8, so that should raise a flag. We're looking at our clavicular heads. Again, they're kind of at an angle. The patient is actually scooted over. Looks like he's flat in the bed, but you can definitely tell this was taken in the bed and the patient wasn't quite upright. Let's see here. Cardiac. Hard to tell where the heart begins and ends, doesn't it? Because it's just kind of fluffy. But you can see the pulmonary arteries are very engorged. There's one, there's the other. This looks flat across, but again, remember that the guy is twisted. So when the guy is twisted, it's kind of hard to tell. D, diaphragms, can't see them. It just sort of melds into the lungs. It's hard to tell if you can see an accurate diaphragm or not. You definitely can't see any costophrenic angle. Maybe one down here, but it's very fuzzy. E for everything else, they mark the left. And then field. So you can see a lot of hazy densities. You can see a lot of vascular markings. So you see all these vascular markings, and that's just engorged blood vessels. You'll see this haziness, and you can see the haziness is more prominent on the bottom than it is on the top because of gravity. Gravity will pull that down. So when you're looking at a chest x-ray with pulmonary edema, you'll typically see the edema more on the bottom part of the lungs than on the top. And then looking at this one, I'll just fast forward a little bit. I know we're supposed to go A, B, C, D, F, but for time, we can see that the costophrenic over here is blunted. This is a blunted costophrenic angle. So there's fluid sitting there. Can't really see all the way over here, but this may look mildly blunted as well. Pulmonary artery, and see what they're pointing out is that this is very engorged compared to our normal one where you can barely see it. This one is hugely engorged. Pleural effusion, again, is fluid present in the pleural space instead of air. And the fluid can also cause compression and consolidation of the lung parenchyma, but instead of being situated in the apices of the lung, they're usually in the bases. And this can be caused by several diseases, such as heart failure, liver failure, cancer metastasis, post-surgical changes, and trauma. And it could also be loculated, meaning that the fluid could be stuck in a certain portion of the thorax, whether by scar tissue or adhesions. It could just be sitting, like right in the middle of the chest in defiance of gravity. So here's a good example of an effusion. You can see our airway. We can see the carina pretty easily. That looks right. Bones, I can see 1, 2, 3, 4, 5, 6, 7, 8, 9, possibly 10th. You can see that the clavicles, they should be straight. She's a little cattywampus in the bed, or the guy, that's the guy. Clavicular heads look about equidistant. They're definitely straight in the bed, but he's a little tilted in the bed. Cardiac, we see a fairly enlarged cardiac, though this could be an AP view. We see our pulmonary artery here, cannot really see one over here. Diaphragm, I can see a diaphragm over here. Can't see a diaphragm at all. This is all just one big mass. E, for everything else, I don't see any markers. And then F, again, you can see that over here there's no diaphragm. It's just all dense white stuff, and this is fluid, just all encapsulating that left chest, or the right chest, excuse me. So this was what we would term a large pleural effusion. And it's probably not from heart failure because our left field is completely clear. So if it was from heart failure or pulmonary edema, we would see, not always the same, but typically would see some effusions on both sides. This is unilateral, so it's probably from some other process. Again, another example, just this big, you'll see like a meniscus of fluid, and it just sort of just sits right there. Typically crawls up the edges of the space. So you're seeing a big density. You can't really see the diaphragm at all. Here's an example of a loculated pleural effusion. And here's why I say it's loculated. You see down here, you can see the costophrenic angle. You're seeing air down here, okay? Now fluid will drop to the base of the diaphragm and then work its way up, okay? But we're seeing air down there. So you say, But up here, we're seeing our meniscus. We're seeing a fluid line, okay? Typically you don't see flat lines on a chest x-ray, especially when it comes to densities. This is fluid. It's just like a glass of water just sitting up there. This is a loculated effusion. It's trapped. Okay, you can actually see the chest tube right there trying to drain all that stuff out. It's a loculated effusion right there. And of course, the thing we worry most about with chest x-rays are lung masses. Lung masses can occur anywhere in the lung fields, but especially with smoking, especially in the apices. And we also need to look for masses that can be hidden in and around other structures, such as the heart, because the lungs extend behind the heart, and you can definitely get masses there. And then if you see a pneumonia, you also want to look to see if there's a mass associated with that pneumonia, because sometimes you can get a lung mass that can squeeze off a bronchiole. The lungs always produce mucus, and if the mucus that portion of the lung produces can't get past that tumor, it'll accumulate and look like a pneumonia. That's what we call a post-obstructive pneumonia. So here's a nasty looking one. So just to go through our pathway again, A for airway, we see our carina, nice and straight. Bones, our clavicular heads are flat. equidistant from each other. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. This is actually a little hyperinflated because we're seeing a lot more bones, and hyperinflated fields typically indicate emphysema. C for cardiac shadow, so we got our pulmonary artery here, we got our pulmonary artery there, we got our heart shadow, everything looks fine there. D for diaphragm, this is a lumpy, bumpy kind of diaphragm, again, very deep. You can see how much more height of the lung you see than you've seen on previous x-rays. This diaphragm also has a weird shape to it as well, but this, again, is higher than this, and we're still seeing our gastric bubble there. F for fields, we have our left marker, and then for everything else, of course, it's very obvious. Lots of tumors, just huge tumors all over the place. Again, you can see they're mostly in the apices. You can see how this is more discrete. This is fuzzier. He probably has some post-obstructive pneumonias here with some masses. Here's some more examples of masses that we're seeing right there, and these small little ones all over the place. Again, there. Most of the x-rays that I've gotten for this class, I've gotten from like remote, like 30, 40 years ago, where people smoked like fiends and there wasn't a lot of good cancer screenings. Here's a good example of abscesses in the lung. So you can get tumors that will form, and then the cores will necrose, and then they just leave big abscesses in the lungs. And here's some good examples of that. Sometimes these abscesses are fluid filled, so you can see the meniscus of the fluid on this one. As I mentioned, sometimes tumors can hide behind the heart. Here's one right there. If you didn't have that box around there, that'd be very difficult to see. That, again, you have to be very careful and be very diligent in looking at every spot. Once you know what normal looks like, you say, I don't usually see a round little bump right there on the cardiac shadow. But if you were just doing it in passing, you could very easily miss that. And that would go from a curable cancer to a non-curable cancer. Let's see here. Another tumor. Sometimes they hide in the periphery behind the ribs. Again, here's one. There's one. I don't know what that is. I think that might be some sort of foreign object. As I mentioned before, emphysema, you'll typically get the hyperinflated lung fields. You may see bullae, just these big empty areas in the chest. And again, when you see emphysema, you want to examine very closely for any kind of mass. So right there is a bullae. And then up here you can see all these dark areas. See how dark these are in comparison to this. So this, so again, going through our pattern, A, airway looks fine. B, bones, clavicular head's fine. 1, 2, let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 ribs. Cardiac shadow, pulmonary arteries look like they're in the right places. Cardiac shadow looks fine. Diaphragms, flat. See how flat that is in comparison with the other ones we've seen. Very flat, gastric bubble there. Maybe a little fluid accumulation in the costophrenic angle, but again, it could be blunted because the diaphragms are just very flat. And then E for everything else, or there's a marker. And then fields, again, this is very dark. Remember, this sort of looks like that pneumothorax x-ray we saw earlier, where you had this just dropped lung and everything is pushing to the side. This is actually emphysema. So you see all these bullae, the lungs are just literally Swiss cheesed with air pockets, and his only functional part of the lung are basically these lower parts right there. Foreign bodies is another thing we need to be careful of. This is a cute picture that I picked up like 10, 12 years ago. So this gentleman was stabbed in the back by a crazy lady. And you can see the knife is very cheap. And you think, holy crud, this guy is skewered. Not. And we'll get to his x-ray in just a bit. So identification, of foreign bodies is essential. If you see something foreign, you want to know what it is, and is it impacting on the patient's condition. So Mr. Stab victim got into the emergency department. They checked an x-ray, and here it is. And you can see the knife, and you can see it's bent. Okay, again, shadow puppets. You can think in your mind that, oh, he's skewered. It's cut his spinal cord. No, it hasn't. Actually, with this gentleman, if you look, the blade is bent. So when it went in, it hit his spinal processes and just skewered right along the tissue of it, the adipose tissue of his back. They didn't really penetrate anything. Oops. So you can identify that. And, looking at his x-ray, airway, bone, clavicular head's fine. 1, 2, 3, 4, 5, 6, 7, 8, 9. It's a crappy x-ray, but, it's there. Cardiac shadow, diaphragms. Can't really see much. It's a poorly exposed x-ray. But you can definitely, you'd expect to see a pneumothorax if it went through his chest right there, and you're not. You're seeing the gray tissue of his lungs there, a little bit of gray tissue of his lungs there. So I wouldn't say that's penetrated into his chest cavity. And in fact, it just, like I said, went across his back and didn't penetrate anything because of the cheap knife. Let's see here. Again, I've put this slides together many years ago. I'm not... Oh, okay. I'm sorry. So let's look at this one real quick. This is actually pretty interesting, looking at it. Airway. So we can see it's kind of shifted. Where's the carina? Right here. Okay. Let's look at our bones. So we have our clavicular heads. They're normal. Spine's a little cattywampus, but nothing horrible. Count the ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Maybe a little hyperinflation there. You can see a costophrenic angle there. Can't see one over here on this side, or in fact it may be right up here. There's our costophrenic angle. So we can see this is much higher than over here. E for everything else, we got lines. What's this in his throat? Coming down here, the tip. Why, that's an endotracheal tube. Carina's up here, buddy. So whoever intubated this person went too far. Okay, and as I mentioned before in my atelectasis section, what happens with atelectasis is where those lungs aren't inflated. So his entire left side became atelectic. So it all squished down, pushed everything up. So you can see his diaphragm's here. His diaphragm should be down here. In fact, this one's a little hyperinflated. So we have the amount of pressure, or the volume of air for 2 lungs in 1 lung. So that's why this is hyperinflated, not getting any ventilation over here. So this is all atelectic, not getting any ventilation at all. This is hyperventilated. So this is an emergent call to the ICU saying, hey, you need to pull the tube back about a good 6 or 8 cm. All right, let me look at this one real quick. So, okay, I know what this one is. So let's look at this one real quick. So airway, maybe a little deviated. Could be because of the position of the patient, but we can see our airway here, carina's there. Okay, we have our bones, so our clavicular head's there. Let's count our ribs. 1, 2, 3, 4, 5, 6, 7, 8, maybe 9. Diaphragm. Right side looks okay. Left side, uh-oh. What's this? Let's look at these other diaphragm pictures just to get an idea what I'm talking about here. Okay. When we see our diaphragms, we can usually see an air bubble, but it's not overly bubbly. And then look over here. This is the diaphragm. Remember, the diaphragm isn't... When you see a diaphragm on chest x-ray, it'll look solid, but it looks solid because of the tissues behind it or that it's covering, the liver and the body of the stomach. When you have air in the abdominal cavity, it will look actually quite thin. And this is the diaphragm right there. Very thin. It's a strong piece of muscle, but it's a thin piece of muscle. So this right up there is the diaphragm. Okay? So left diaphragm is elevated. A lot of air, intra-abdominal air, is seen over the left diaphragm. So that's something to take note of. E, everything else. All right, so we have our marker. What's this? What's that radiopaque line? That, my friends, is a chest tube. Something's not right. Okay, and then F for fields. We have a bit more hazy density there, maybe a little atelectatic. Okay, maybe a pneumonia, can't really tell. So the story behind this one is someone put in a chest tube and went too low and they perfed the diaphragm. So now we're getting intra-abdominal air, we have our chest tube in the wrong place, and that, of course, is an emergent situation. All right. If I remember right, this one I believe is a swallowed tooth. Right there, this is what I'm looking at right there. That's not too interesting, not as interesting as this guy. But yeah, I believe that was an inhaled tooth. Hold on, let me take a look at this. Oh, okay, I see what this one is. All right, so let's look at this one real quick. So we have our airway coming right down there with our carina. We have our bones, so our clavicular heads. It's a little crooked in the bed, but nothing too bad. We look at our bones, 1, 2, 3, 4, 5, 6, 7, 8, 9-ish. Diaphragms are fuzzy. Can't really see a diaphragm down there. Okay, so very hazy, not very distinct. Wait, I forgot our C. Forgot the cardiac. I'm sorry. So we have our cardiac shadow there. There's a pulmonary artery there. There's a pulmonary artery there. If you take in consideration for his skewedness in the bed, that looks about right. But he does have a bit of vascular congestion there. Here's our horizontal fissure. That's right across like it should be. Okay, what's next? We have our everything else. All right, so we have our marker. Looks like we have the central line here. Actually, that's that's a swan, I believe, coming down here, and then going up there. There's a tip right in the pulmonary artery. And then what's this up here? It comes down, it goes up, it comes down, and there's the tip. So the story behind this one, a nurse put down a Dobhoff, and Lord knows how this happened, or why they put this much of a Dobhoff down the patient, but it looks like it became entrapped. Instead of going down the esophagus, they went down the trachea and up the trachea back to the top of the mouth, and went back down, and then ended up in their left lung. And considering this haziness, hopefully they didn't give any tube feedings through it. It's a possibility. I don't know the whole story behind it, but that's what that is a Dobhoff. This one is a common one you'll see. Pacemaker. This is actually we call a dual chamber pacemaker. So we have a pacer lead up in the atrium and then one down in the ventricle. Okay, here's an interesting one. So, same patient. You can see this area right here. If I remember, hold on, I got it. Looking for my lines. Okay, I'm sorry. Again, I haven't seen these films in a few years. I believe the story behind this one is, if you look at this one, this is a swan catheter, and it comes down, and the tip of the swan is there. And as anyone in the ICU knows, that's way too far. That's very much wedged down into the pulmonary arteries. And I'm assuming it stayed there for a while and then got this infarct here. But again, I'm not entirely sure because this is label A and this is label B. So again, it's been a number of years since I've reviewed these slides. I think that may be the story behind it, but I'm not quite sure. We'll just move on. So heart abnormalities. You see this and you say, did they put the marker on the wrong side? But you won't be tricked by this because you do your x-ray reading in a thorough manner, because we have our airway with the carina, we have our bones, okay, we have our C for cardiac, okay, it looks like the heart is flipped, but maybe they put the film up backwards, maybe it's reversed, we don't know. Let's take a look at the other things. D is for diaphragm. We're seeing a gastric bubble here, we're seeing the liver here. Why is the heart over there? Let's see, everything else, no markers, lung fields, everything looks okay. You can definitely tell this is a woman. So this lady has dextrocardia, where, in utero, the heart wound up on the right instead of the left. And not quite sure what this one was. I believe this is a pericardial effusion. You see this super enlarged heart shadow, very large, not just cardiomegaly. I would say this is high likelihood of a pericardial effusion. And the one behind this one, you can see this meniscus here and a meniscus here behind a heart shadow. And you say, what the heck is that? Well, this is where a lateral x-ray becomes important, because you can see a meniscus here and a meniscus there. This person has a large hiatal hernia. This is all stomach. So this is the stomach and the gastric bubble coming up. And that's it. Thanks so much for listening. I hope this was helpful. If you guys have any questions, please contact me in class. And if you want to go over some more, I might be able to find some more x-rays. Thanks a lot.